Welcome, everyone. Thank you so much for joining us tonight. We have a great program for you in honor of Endometriosis Awareness Month. Our speakers tonight are experts in minimally invasive gynecologic surgery and fertility and have a great deal of experience diagnosing, treating, and managing uterine fibroids. And tonight with us, we have Dr. Chetna Arora. She's an assistant professor here at Columbia University. She completed her minimally invasive gynecologic surgery fellowship here at Columbia. And then we have Dr. Iris Insogna. She's a fertility specialist with Columbia University Fertility Center. Before joining Columbia last year, she completed her residency and fellowship in reproductive endocrinology and infertility at Harvard Medical School, Brigham Women's Hospital. And then we have Dr. Jessica Opoku-Anane, who joined Columbia earlier this year from the University of California, San Francisco, where she was the director of the Endometriosis Center. Tonight, I'm going to ask our panelists some questions related to fibroids. And we also invite you to submit any of your questions in the Q&A box, and we will answer after the presentation. Let's get started. So our first question is for Dr. Arora. What should patients look out for in terms of symptoms if they think they might have fibroids?
I think this is such a good beginning question because a lot of people don't even know they have fibroids. It tends to be something that you find often incidentally if there really aren't any symptoms, maybe on exam. But when people do have symptoms, they can be pretty mild to relatively severe. There are small symptoms with just maybe some irregular periods, but then abnormal uterine bleeding can become significant. If any period extends beyond a normal duration, occurs more frequently, has a heavier flow, it could be a sign of fibroids. The other things that are really important to consider when it comes to fibroids is just the mass effect. You know, our pelvises are made to expand and be able to hold a variety of sizes of masses, even just say for pregnancy. And we can go quite some time without being aware that fibroids are there, but they can cause things like compression on the bowel, that can be like constipation. If it pushes pressure on the bladder, urinary frequency, urgency, getting up in the middle of the night, that's called nocturia. There can be also other issues that are beyond even just the quality of life issue, but putting pressure on important organ systems like blood vessels and kidney tubes and having some downstream effects. And I know that Dr. Insogna is here too, and she's going to definitely talk about the fertility aspect, but that does have an impact depending on where fibroids are located. If they're located on the inside cavity of the uterus or really distort the uterus, which we will definitely get into a lot of detail. This picture is particularly nice to describe. It's a really great opener. It feels really busy, but I want to kind of break it down. If you follow the numbers from 0 and as they get bigger, if you notice what I want to say here is the inside cavity of the uterus is where the 0, the 1, the 2, and the 3 kind of order. That's where a pregnancy would implant. That's where the lining of your period would shed every month. But what happens here with a type 0 fibroid is it's fully in the cavity and it really can cause some pretty significant bleeding. A 1 and 2 can also similarly do that, as well as a 3. But generally speaking, when fertility comes into play, if you have fibroids and enough of them, they can make the whole uterus change in shape, can cause issues with contractility, and sometimes they need to be surgically addressed.
Thank you so much. And that was the perfect segue for our next question to Dr. Insogna. How often do you encounter fibroids as a barrier to patients becoming pregnant?
It's a very good question. And just like Dr. Arora was saying, sometimes we find fibroids incidentally. So true infertility caused by fibroids and fibroids alone is not all that common. Usually what we call uterine factor infertility, meaning infertility specifically related to an issue with the uterus itself, is only found in about 3 to 5% of patients presenting with issues getting pregnant. But again, we do find fibroids much more commonly than that, incidentally, that people just didn't know they had. And whether they're contributing or not to the overall picture of their fertility issues is really case dependent. So I included this slide just to show you that there's lots of different ways that fibroids can affect the ability of an embryo to implant. And that's really a critical part of reproduction, and one way that fibroids definitely can impact your fertility. So this slide from a journal article that was published in Fertility and Sterility just kind of highlights a couple of ways that fibroids affect the uterus. So it can certainly, fibroids that are positioned near the cavity or inside the cavity, or even fibroids that are abutting the cavity, like that number 3 fibroid that was shown in the last slide, those fibroids that are anywhere near the actual inside lining of the uterus where the embryo is going to implant, where the pregnancy will develop, can be troublesome. They can impact blood flow to the uterus and the normal surrounding myometrium. They can impact certain factors, growth factors that are really critical for implantation to happen. They can distort the cavity. They can cause contractions of the uterus that can make it hard for an embryo to implant, certainly in the setting of an embryo transfer when someone's doing IVF. So all of these things really come into play. And in terms of which types of fibroids need to be addressed in a fertility setting, it really boils down to 2 main factors. One is the location of the fibroids, which we've talked a little bit about now, and 2 is the size of the fibroids. So certainly any fibroid that's near the lining, we usually like to address up front because we know that those can be an issue. But even fibroids that may not be touching the cavity itself or abutting the cavity or inside the cavity, even fibroids that are just in the muscle of the uterus may need to be removed if there's enough of them or if they're big enough to cause an issue. So that's why we work really closely with our minimally invasive GYN surgeons here, who I share a lot of patients with, because it's an important thing that needs to kind of be co-managed to help optimize the reproductive outcomes for our patients.
Thank you so much. And again, segueing from that, Dr. Arora, what are the options besides surgery to treat fibroids?
I mean, there are a lot. I tell patients this in kind of buckets. 1, you could do nothing. 2, medical management. 3, procedural management. And 4, surgery. It kind of just depends on what the goals are and what the timeline of events are hoping to be. For observation, I think it's reasonable if the bleeding is not really bothersome, isn't associated with anemia, and is something that does not affect quality of life. Then when it comes to medical management, say someone is nearing menopause or doesn't have big mass effect from fibroids, or is someone who doesn't desire future fertility, or the fibroids are not in a spot that would be troublesome for future fertility, medical management is an option. Options include things like progesterone-only medications, estrogen progesterone medications like a birth control pill. There's lots of things out there, pills, patches, rings. These really help with just the bleeding aspect. They don't really affect the fibroid aspect. Fibroids are masses of reproductive potential. So until you reach menopause, they're going to probably keep growing or stay the same. Often there's a slow growing process. The more you have, the generally bigger they get over time. If you have 1 or 2 when they're little, you could probably get by. But generally speaking, medical management is a viable option. There are some more intensive meds that are available, but they are time limited and have some side effects. And there's something you should talk about in more detail with your doctor. We can always go into them too if the questions arise. Other things include procedural management. And I know that Dr. Opoku-Anane is probably going to talk about this too. But there are things like just doing something called a uterine artery embolization procedure. That is a procedure done by interventional radiologists. It's not done by GYNs. But what happens is that they put a device into the groin, and then through the groin, they follow the blood vessels up to the uterus and they actually block them. You can block the blood supply to the whole uterus itself, or you can block them to select fibroids. Depending on the goals and the situation that is at B, whether it's an emergency and there's a lot of heavy bleeding, we're trying to preserve the uterus or protect the patient from heavier blood loss, that's an option. But in terms of like a regular outpatient setting, it is an option for people. Arguably, it's more for the side effects of bleeding profile with fibroids. It doesn't as much shrink fibroids collectively. So if the uterus is really large, that shrinkage is not extensive. It really depends on where your fibroids are, how many you have, and the location of them before a uterine artery embolization procedure could be considered appropriate for you. One very important caveat to this is that if anyone is desiring future fertility, even a thought, should not get a uterine artery embolization procedure, because it can compromise the vascularity of the uterus itself, which can have significant obstetric complications. I know that Dr. Opoku-Anane was going to talk about things like MRI guided ultrasound. We also have something called the Sonata or it's basically radio frequency ablation. I can let her take the lead on that one. And the last one is just surgical procedures. So there are a lot of options. If fertility is not desired and the uterus is really large, the options include something more simplistic, like a hysterectomy. It's simplistic in thought, not in actually doing, which I can totally respect. I know that that's a big decision for a lot of people. But as minimally invasive GYN surgeons, we have a goal of quality of life. So we make minimally invasive incisions, and we don't take out ovaries unless they need to come out. So typically the plan for when people decide to do things like a hysterectomy, it's uterus, cervix, and tubes. The ovaries rarely are removed. The ovaries are what provide all of the hormonal benefit. So no menopause, hot flashes, night sweats, things like that. Good for brain, bone, and heart health. All of that stays. Now, if fertility is desired, there is an option for surgical intervention with just a myomectomy. And that's a fancy way of saying just taking out the fibroids and leaving the uterus intact. There are lots of routes of that. And I know we're going to touch on that soon, but there are hysteroscopy, robotics, laparoscopy, conventional laparoscopy, and open approaches if necessary. And sometimes we combine a couple of routes in one go.
Thank you so much for that. And I would like to turn it over to Dr. Opoku-Anane. How do you evaluate patients for surgery versus medical or other types of management?
Every patient who comes into our practice is really given an individualized plan. So this is really depending on the goals of care for the patient. So things that we will ask about are what symptoms are you having, as mentioned before? Are they more bleeding symptoms? Are they more bulk and pressure symptoms? And what your fertility desires are. Because that really determines which type of treatment option we can offer you. The other questions that we consider are, what is your past medical history? What prior surgeries have you had, and your risk for complications with different treatment options that we might offer? And then we generally will do an exam as well as some imaging, either an ultrasound, sometimes an MRI, sometimes something called a saline sonal histogram, where we specifically look to see the inside of the cavity and which ones might be pushing in towards your womb. Or even take a look with our camera directly in the office, called office hysteroscopy, to assess the same thing. Once we have a better sense of how many fibroids you have and the size and the location, then we can give you a sense of what options are available to you. And Dr. Arora talked a lot about the different medical treatments and some of the procedural treatments and the surgical treatments, and that's all dependent on that initial evaluation. I do think that I want to emphasize that it really matters about your goals of care. So we let our patients drive us. A lot of patients will come in one way or the other. Either they just want definitive management, they want to get rid of these fibroids, they don't want to think about them ever again. We lean more towards a hysterectomy. Or they absolutely want the least minimally invasive option possible. Sometimes that's medication management. Sometimes that's a small hysteroscopic myomectomy to remove a fibroid. But it really kind of depends on what the goals are for the patient. And when we think about fertility, I think that this is a complex interaction often with our fertility doctors to discuss what's going to be the best thing to optimize your ability to get pregnant. And that is dependent on your age, it's dependent on where your fiber is located, the size, and also how many kids you want to have. So there's so many different factors, but the point is it's really individualized. And it is important to go to a doctor who is working in a multidisciplinary team, as we are, who can tell you the different options and provide all the different possibilities that you end up with the option that's best for you. And just to Dr. Arora's point, because this does come up quite a bit, there are a couple of other procedures that can be done and that are similar to uterine artery embolization. We often don't offer these as often because the outcomes are pretty similar to uterine embolization, often with just a few days difference recovery. But a lot of times patients will ask us about these procedures such as MRI-guided ultrasound shrinkage or radiofrequency ablation. There are other procedures like cryotherapy, which are all meant to try to shrink the fibroids. They're more experimental. They do have some success rates in certain patients, in particular patients who don't have too many fibroids or don't have too big fibroids. But because they're experimental, they're often not covered by insurance, so they're a bit pricey. And also, we don't have the evidence to prove that they're safe in pregnancy. So there are very limited number of patients who are able to benefit from those procedures.
And then piggybacking on that, what are the chances that fibroids could return after treatment?
Yes. So, the chances of fibroids returning are based on the type of fibroids you have. The more fibroids there are, it's very likely that they're going to come back. So some patients will come in and they have maybe 30 fibroids or up to 100 fibroids. You have a lot of fibroids. The more fibroids you have, the more likely it is that you may have a fibroid that comes back or that we miss a fibroid, especially if they're really, really, really small and many. And the rates actually vary depending on what procedure is done, whether it's a myomectomy procedure to remove the fibroids or it's one of the procedures to shrink the fibroids. They vary anywhere between them coming back between 25% to 50% and the duration of time that we're talking about. If you are in your later 40s, the chance of them coming back are going to be much less than if you're in your 20s. And that's just because, as Dr. Arora mentioned, these fibroids really grow in response to your normal reproductive hormones, your estrogen and progesterone. And so the longer amount of time that you have exposed to estrogen and progesterone, the more likely it is for them to come back. And then, so it depends on how many fibroids you have. The second thing is how close you are to menopause. And then the last aspect that can affect the rates of recurrence are if you, how big, not so much, but more if it's one single dominant fibroid. That is a perfect candidate to have it removed because it's very unlikely that it will come back, or it'll come back in a way that means that you're going to need repeat surgery or a procedure.
Thank you for that. And Dr. Arora, can you tell us about the chances that fibroids could be cancerous?
Yeah, I absolutely. I think just to turn the conversation around a little bit and say, I know fibroids in general can be pretty burdensome as a thought, and, realizing you have them, it feels very, like it's a pressured decision and got to do something about it. And then that kind of spirals into the, what is it going to do to my body? What is it really dangerous for my health? Could it be cancer? The large, vast majority of all of these fibroids are just a nuisance. They're not cancer. They cause symptoms in some people, but I could almost assure you if we scanned every uterus in all of New York City, there's going to be a lot of people who would have surprise fibroids and no symptoms. And so when you find them, it's the first thing I would say is just don't worry. Don't freak out. There are a lot of options. And when it comes to doing the workup, we do the things that we kind of described. We'll do an exam, we'll get your history, we'll find out what medications you've been on. Maybe you've been on a birth control for contraception. You've actually been treating your bleeding this whole time. You never know. And then we'll do things like an ultrasound. If we're planning surgery, we like to do the MRI. It's great for surgical mapping, but it's also great in showing the characteristics of fibroids too. So fibroids on an MRI can really map out the size, location, and the number, but they also show consistency, and we use special contrast tools to kind of look at different fibroids and their characteristics. Generally speaking, fibroids, a cancerous type of fibroid would be a terminology called leiomyosarcoma. That phrase and that word might be a bit of a buzzword for some people. I'm sure people have read about that on social media or heard about stories about that. But generally speaking, the rate is like less than 1 in 1,000. And this is something that is not perfect at diagnosing preoperatively, but we look at a lot of risk factors and we look at what the goals of the treatment are. We take things and we stratify risk. So we look at the age of the patient. We look at the bleeding profile, particularly look at when were fibroids noticed and how rapidly have they grown. If there's an ultrasound from some time ago and maybe one more recently, and there's significant interval growth, that might be a cause of concern. But generally still, fibroids are very reproductive potential masses. There are a few things that we can do to rule out cancer, but it's still not a perfect science. The only way to really rule it out is to have a pathologist look at it under a slide. And that kind of defeats the purpose sometimes in terms of a conversation. We can do something like an endometrial biopsy in the office, combine it with some special blood work, as well as the MRI I mentioned. And if you put all of those factors together, you can kind of stratify the risk to the patient and what the likelihood of malignancy would be, in addition to what their age is and the characteristics as described before. But I will tell you, most of us who've been in this field, it is incredibly rare that we'll encounter a leiomyosarcoma or uterine cancer that was not predicted before. And the reality of it is most of us, when we are doing the workup and we have a concern, we know it before the surgery even really starts. There is something I kind of want to segue into as well. And I know the terminology morcellation may be coming out too. And I bring it up with the cancer talk because I do think it's a little bit important to say. We don't use power morcellators anymore. That's been gone for some time. Everything that we do, if we do it surgically and we are removing fibroids, the fibroids are placed in a contained bag and they're hand cut out of the belly, contained in that bag system. Same with the uterus. If the uterus is being removed altogether, the uterus is fully contained in a bag through a minimally invasive incision. And no matter how big that uterus is, sometimes if we're committed to minimally invasive, we'll get it out of a little hole through the belly button.
Thank you so much. That was extremely helpful. And Dr. Opoku-Anane, are there any way to prevent fibroids?
That's a great question. And I see that was one of the questions that's in the chat. There are multiple different options that have been thought may be helpful in preventing fibroids, but we just don't have a great amount of evidence for these things. So I'll start first with what has the more evidence, and then we'll go into other things that might be helpful. I think probably the best evidence is for treating vitamin D deficiency, which is pretty common. We think that vitamin D can have an impact on fibroid growth and progression. And so if you have been checked and you are vitamin D deficient, definitely thinking about supplementing with some vitamin D should be helpful. It's also really important for lots of Black patients because vitamin D deficiency is very common in people with more melanin. It just inhibits vitamin D. So, supplementing with vitamin D is probably the thing that has the most amount of evidence, although there hasn't actually been a study to look at a lot of patients to give them vitamin D and see what happens after that. We just know that people who are deficient have a higher progression in their fibroids. Other things have been discussed and are based on the mechanism of fibroid growth. So probably avoiding reproductive toxins, or we call them endocrine disruptors, such as like BPA and phthalate, which people are much more aware about. That might be helpful. Those type of medications can increase their exposed estrogen and progesterone and may be associated with fibroid growth or development. Again, there's no clear evidence, but this is based on the mechanism of fibroids. Fibroids have also been associated with obesity and high blood pressure. So having a good lifestyle, exercising, those type of things could be helpful. And then in terms of the diet, a lot of people ask about the diet. I think that there's not clear evidence, but there are some small studies that are suggesting avoiding things that are high in estrogen and progesterone maybe will be helpful. And a lot of the other things are inflammatory. So things like red meat, alcohol, going more organic and avoiding meats and things that might have reproductive hormones to help them grow. There's not evidence for it, but honestly, that's probably a good thing to do for many disorders that we have around. So it is something that I recommend to my patients. We use it for almost all inflammatory disorders, all disorders that are mediated through reproductive hormones. And it's a good lifestyle in general to prevent a lot of bad things. So I routinely do recommend commonly treating any vitamin D deficiency If you are darker skinned or Black, just going on to vitamin D supplementation and considering these diets that mostly decrease inflammation and often will help with the symptoms of endometriosis and or decrease exposures to estrogens and progesterone.
Thank you so much for that. And Dr. Insogna, how does treatment for fibroids affect the patient's chances of becoming pregnant?
If the fibroids have been contributing to infertility or difficulty getting pregnant, then typically when you remove the fibroids, it usually helps quite a bit. It bears mentioning that anytime we do any type of procedure on the uterus, including things like removing fibroids, there is a chance that scar tissue can form, though that's pretty uncommon. So typically we just want to make sure we give the cavity plenty of time to heal before we launch into fertility treatment. Or if people are trying to get pregnant on their own and they don't have any fertility issues, again, we still want to just make sure that the uterus and the uterine cavity have plenty of time to heal after any intervention. And like I said, the incidence of having scar tissue form inside the cavity is pretty uncommon. And even if that does happen, generally we can address that as well through a minimally invasive surgery. When it comes to timing of attempting to get pregnant, whether that's spontaneously or through IVF or any other fertility treatments, generally we counsel patients depending on the type of surgery or the type of intervention that they've had. So if you've had a hysteroscopic myomectomy, which means no incisions on the belly, just done, through with a small camera that goes through the cervix into the uterus, and the fibroid is resected that way, then there's not been any incisions made in the muscle of the uterus itself. And so that's pretty much as minimally invasive as it gets. And for that type of case, we generally say after about a month, once you get a full cycle and a full period again, it's really okay to try getting pregnant, however you need to do that, whether it's with assistance or not. If you have a larger case removing larger fibroids that requires incisions on the uterus itself, so whether that's done laparoscopically, robotically, or with an open incision, an abdominal myomectomy, anything that requires actually incisions on the uterus, we want to give more time to allow healing to happen. So generally the recommendation is at least 3 months to really let everything heal. Those incisions through the muscle, through the full thickness of the wall of the uterus could be a potential site of weakness. And so what we want to make sure to avoid, we want to reduce the chances of uterine rupture in a pregnancy where the uterus can stretch and even break open at those sites of weakness. So that's why it's really important to make sure that the healing process has plenty of time to take place. For some women who've had many fibroids removed or a large incision on the uterus, then we also might recommend considering a slightly earlier term delivery. So still delivering a pregnancy at full term, but on the earlier end of what we consider full term, around 37 weeks. And we may recommend a C-section for those women, again, because we want to reduce the chances of having a uterine rupture. So these are just some considerations in terms of fertility, reproduction, obstetrical outcomes, and all things that, it's helpful to, again, be part of a multidisciplinary team so that we can all counsel patients appropriately from these different angles.
Perfect. Thank you so much. So I see that we have a ton of questions in the chat, so in the Q&A, sorry. So I definitely want to move over to those just so that we have enough time to answer them. And so what I'll do is I can just pose the questions to all of you and whomever would like to take it. And if multiple people would like to answer it, I think that's super helpful. So one of our attendees said, I am 6 weeks pregnant and I have a very large fibroid. I already had a lot of bleeding. What can I expect for the rest of my pregnancy and how will it affect the baby?
I'm happy to answer. Congratulations, first of all. That's number one. It seems like a very exciting, but also suddenly probably very worrisome time in your life where everything starts becoming you're more aware. I will tell you a lot of women have fibroids when they get pregnant and there's nothing to it. First trimester bleeding can be for a lot of reasons. It can be just from the pregnancy itself and everything is completely fine. It can be from maybe sometimes bleeding where there's the implantation of the pregnancy. And it could be also, because we're here talking about the fibroids, it could be from the fibroids and that implantation site. Generally, that's not typically a problem. A lot of people have bleeding in pregnancy for more benign reasons. If the fibroid is at all in a tricky spot or maybe pushing on the cavity, as Dr. Insogna has said, it can become something that we need to look at. I would tell you that you probably should have a follow-up with your doctor, get an ultrasound, find out where that fibroid's located. In terms of taking care of it while you're pregnant, we actually don't. We leave it in place. Doing any surgery while pregnant is obviously definitely going to be a challenge, but on the uterus itself could be particularly complicated. You don't want to compromise the blood supply, and that blood supply gets pretty rapidly bulky pretty fast in a pregnancy, so we would leave it alone. There's also a commentary about taking them out at the time of C-section. We don't recommend that. That comes up a lot actually in the clinic. And the important thing to say is that your uterus is very highly vascular. So if you think of like a blood supply, like a blood vessel that's like the shape of a size of a coffee straw, when you're pregnant, it's like a boba tea straw, and they're everywhere. So you don't really make an incision to take out a fibroid at that time.
So we have another question here that said, how important is it to remove fibroids once you know that you have them, assuming that you do not want to get pregnant?
I can answer that question. You know, the thing that we get this question a lot. A lot of patients have an incidental fibroid picked up because they had imaging for some other reason. And what do you do about that? In general, if you're not having any symptoms, we usually recommend that you do nothing. That's because fibroids are extremely common. You know, 70% of all patients with uteri, but also like 80% in certain populations. So, and most of those people are able to live normal lives and get pregnant and not have any issues from the fibroids. So it's really when it's symptomatic or affecting fertility that we start thinking about doing something to intervene. Because although we always approach a minimally invasive approach, everything that we do can have some type of side effect. So, you know, there are concerns about, could this fibroid eventually grow into the position that will cause some problems or symptoms or problems with fertility? But it's really hard for us to know that or guess that for a patient. Oftentimes what we will do is get some repeat imaging at 1 or 2 years to see the rate of growth, because that can give you a sense of whether this is something to be worrisome. It's growing like 3-4 centimeters every year, or whether it is staying pretty stable in size and it's been 1 centimeter and it's been staying 1 centimeter for the last 3 years. That's probably something you don't need to do anything about. The other consideration is to think about how many procedures you may have over a lifetime, because the fibroids do grow in response to our normal reproductive hormones. If you're in your 20s and you're starting to have your procedures then without having any symptoms, it's very likely you're going to have another fibroid that might come back and cause symptoms, or it might cause fertility and need another surgery or another intervention. And although doing a lot of these minimally invasive procedures once or twice there's not that many risks to it. But if you start having repeat surgeries, you risk things like scar tissue and nerve pain and other things that can cause problems in the future.
Thank you for that. And then I think that this is a good question for Dr. Insogna. Can you talk a little bit more about the impact of fibroids on delivery for those identified or enlarging during pregnancy, specifically large 10 centimeter Subzero fibroids in the lower uterine segment? So I know you talked a little bit about delivering early and the probability of a C-section, but is there anything else that we can kind of elaborate on with that?
So for fibroids that are identified in pregnancy, once you're already pregnant, just like Dr. Arora was saying, we usually do not intervene on those. We usually just let them be, and they may not pose any real concern when it comes to delivery. So if you have a fibroid that's already present and you're pregnant, even if that fibroid enlarges, that may not mean that you have that you have to have an operative delivery or a C-section, you may very well be able to have a vaginal delivery. And probably based on the description of that fibroid, it may actually be better and easier to have a vaginal delivery. So it's not at all a contraindication to a vaginal delivery just to have a large fibroid present. And hopefully, it won't affect too much in terms of the delivery. Sometimes, fibroids can affect the ability of the uterus to contract, or potentially, if they're really substantially enlarged, could pose an issue with moving through the birth canal. But again, it's less likely for that to happen. And it's good to be aware of the fibroid, because if it does, have any bearing on the delivery itself, the option for a C-section is always there. And the C-section can always proceed, even if there's a large fibroid in the lower uterine segment.
So we have an interesting question here from one of our attendees. They said, I'm a fibroid patient on the younger side for whom discussions of desired fertility with my doctors are difficult. What suggestions do you have for patients to clarify reproductive goals if they're not in that place?
Okay. I think this is I'm sure all of us will probably want to kind of speak on this maybe, but I appreciate that you brought that up. And I think it comes really important with bodily autonomy and speaking up for yourself. And we are in the world where many opinions are possible. And I always encourage my patients, especially in New York City, a lot of people are actually looking and talking to multiple people, as they should. But you should feel comfortable with your doctor. You should feel secure with your physician and your plan. And if you don't feel like the conversations are easy, it is absolutely your right to go have another conversation. If then you still don't feel like you're comfortable, of course, all of us will be happy to see you. But generally speaking, this is something that when you are younger, it is important to advocate for your awareness of your fibroids, because we very often end up seeing an unfortunate situations where women are in their later 30s, early 40s, seeking fertility and have fibroids that have gotten very large. Minimally invasive surgeries become sometimes not possible to do, and the recovery can be different, and the fertility outcomes can be different. So I very much think that if you know you have fibroids and you are having any symptoms at all, or even no symptoms, it is important to be aware of them. We don't actually recommend routinely screening, so to speak, for fibroids unless people have had large fibroids or they've had surgery in the past or their bleeding is different. But if you follow with a provider and you keep all of your imaging records together, we can look at things over time. And the exam can be very helpful in deciding whether or not certain fibroids have gotten larger and interventions need to take place.
Yeah, I totally agree with your point that, we are very fortunate to live in a resource-rich setting with many hospitals and many, many physicians. So I think the option to seek a second or even a third opinion is a really important one to keep in mind, because these are critically important decisions that you're making about your body, about your reproductive health and your reproductive future. And you want to make sure that you are in good hands with somebody that you trust and who respects your decisions.
Another question here says, would fertility hormone meds create fibroids or increase the likelihood of getting them?
That's a really good question too, and I'm happy to answer that. When we use medications for IVF or even for things like ovulation induction, oftentimes the medications raise the estrogen levels. So they'll raise the estrogen levels in the blood temporarily. And the truth is that it's such a fleeting elevation, usually for only a week at a time if we're using pills for ovulation induction, or about 2 weeks at a time if we're doing IVF, that really doesn't have any systemic or long-term systemic effects. So really it shouldn't have any impact directly on fibroids. It shouldn't have, definitely doesn't cause fibroids, and it should not cause them to grow, because it's such a fleeting moment in time. And truthfully, for women that are seeking to become pregnant, your estrogen levels will be much, much higher throughout the course of your pregnancy. So the fertility treatment alone really doesn't have a long-lasting effect in that way.
And we have another question related to that. When I went When I underwent IVF, I was told that I have one fibroid, but because it was outside of the lining, it wasn't a concern. I would still like it to be removed. Can I still do that?
Yes, that option still exists to remove the fibroid, but I would have a conversation about the exact location of it. Is it near the lining at all? And how big is it? Because those are really the two most important factors when determining how important it is to remove. Not all fibroids really have an impact on fertility, but the ones that are usually over 2 centimeters or anywhere near the lining are the ones that really should be considered for removal. But I would, have a conversation and potentially more imaging to see the status of that fibroid at this point.
And someone else is saying that they're aware that it probably varies widely, but egg freezing with fibroids. Can you discuss the risk factors, and can hormones worsen a fibroid issue long term, which we touched upon?
Yeah, I think just the egg freezing consideration, or IVF in general, really is about access to the ovaries. So if we're able to visualize the ovaries transvaginally or sometimes even transabdominally, if we're able to access the ovaries in spite of the fibroids, then undergoing an IVF cycle for egg freezing or to create embryos is still very much an option. We do sometimes encounter situations where the fibroid burden is so great that it actually compromises our ability to visualize the ovaries or to access the ovaries. And in those cases, we often work very closely with our surgical colleagues to potentially have a myomectomy in advance to remove the fibroids, to really make it easier and more accessible for us to actually perform an egg retrieval. So it is a case-by-case decision, but again, really important that we have really good working relationships with our colleagues so that we can discuss that if those situations arise.
Thank you for that. And then someone else here has a very interesting question. They said, how often do you find out when you're doing fibroid surgery that the patient also has endometriosis? That this had happened to them, and they're wondering if there's a common combination and if there's any theories about their coexistence.
Yes, it's actually very common. So, our residents or trainees, they laugh. I just put possible excision on endometriosis on everything. But part of the issue is that the symptoms for endometriosis and for fibroids often overlap. Both of them can cause issues with the bowels, issues with urination. Both of them can cause discomfort. So it's common that it can be misdiagnosed. And also they just commonly go together. A lot of people have both fibroids and endometriosis. And that's probably because they both grow and respond in response to your normal reproductive estrogen. And not so much progesterone for endometriosis, but in particular estrogen for both fibroids and endometriosis. So it is important that you go to someone who feels very comfortable managing both endometriosis and fibroids. And if any of them are present at the time of surgery, they're able to handle both.
Another person is saying that last year they had a fibroid removed that became symptomatic and caused extreme pain and blood loss. And then recently they went back in for a sonogram and found 3 new fibroids. Their provider had suggested surgery, but this person is asking if they should wait until they become symptomatic.
It's a good question. I can take that one. We always look at patients when they've had one myomectomy, they kind of, in our minds, start a timeline. And we kind of put them in a space where we want to time any future surgeries if their fertility is a desire or if symptoms arise. Depending on how old this patient is, where they are on their fertility goals, and what symptoms there is actually a consideration for truly observing. You don't always have to do something about it, but if the fibroids are starting to become more symptomatic, then sometimes the right answer is quality of life, and that could mean surgery. Unfortunately, I think Dr. Opoku-Anane also mentioned this, is that when you have a high fibroid burden, it's very likely that there are residual microscopic, pea-sized, we call them seedling fibroids that are still present within the uterus that are going to progressively grow with time. When we do myomectomies, our goal is always preservation of uterine integrity. we're not trying to obviate the purpose of the uterus if fertility is desired. And so going after every single fibroid doesn't really maintain the goal. You can make a uterus look really pretty and take everything out, but then does it work really well? Maybe not. And so we have to kind of balance that. And I'm sorry that your fibroids have, returned and surgery may be a question for you. But this is, unfortunately, when the fibroid burden is relatively high, this is a common presentation. And that's why a minimally invasive approach every single time, or when feasible, is ideal. So you can minimize that scarring and that effect. If symptoms again are present, surgery should probably be considered, but seek another opinion, find out.
And then we have someone else here that I know we had touched upon this, but they said, that in their research, they have read that using food to assist with management. What are everyone's thoughts on using diet to manage fibroids?
I mentioned my thoughts. I think there's not a lot of evidence. There are really small studies regarding the use of dietary changes to help with fibroid growth or progression, and none that really say prevention of fibroids. But I do think that it's a very safe intervention, and it's not harmful. And based on the mechanism of how fibroids grow, most of the time actually, I recommend some dietary changes. In particular, vitamin D, treating any vitamin D deficiency, because there is evidence for that. Otherwise, avoiding things that are high in estrogens and progesterones, which a lot of times means also going organic, and inflammatory foods. Oh, we can't hear you anymore.
Sorry. How long after surgery should someone wait before getting pregnant again?
So again, it depends on the type of surgery and the approach that was used. So for women that have had a hysteroscopic myomectomy, meaning a surgery where there's a camera inserted through the cervix into the uterus and you resect the fibroid that way. So there's no incisions on the uterus, no incisions in the abdominal wall. It's just all done internally. That is a very minimally invasive approach. And so women typically can attempt pregnancy about a month after their surgery. So once they've had a complete cycle and their next period, they can usually try. For women that have had a larger surgery, so any type of laparoscopic myomectomy, robotic myomectomy, abdominal myomectomy through a larger open incision, that is a bigger procedure that requires incisions, at least one, sometimes several incisions through the muscle of the uterus, sometimes through the entire thickness into the cavity, though not always. But anytime there's incisions on the uterus itself, then we want to give a little bit more time for it to heal. So generally at least 3 months for a healing process after those bigger surgeries before trying to get pregnant.
Another question here is, if surgery involves reconstruction of the uterine wall, will the pregnancy be considered high risk?
So not necessarily. Sorry, go ahead.
All those. Go ahead.
So not necessarily. Again, that's the potential site of weakness in the uterine wall when there's a scar over that. But similar to a C-section where you've had an incision through the full thickness of the uterine wall into the cavity, that should heal with time. And we're aware anytime that there's been an incision on the uterus or healing at that site, that it could potentially be a site of weakness. It could potentially, in rare circumstances, 1 to 2% at most, result in a uterine rupture at delivery, or when the uterus starts to contract, the uterus can kind of break open or weaken at that site as it stretches. That's really not very common. Again, 1 to 2% probably is even overestimating it. It's probably even less than that. But that's the concern. And so that's why we would just be aware of it, but it doesn't necessarily mean that you're at a higher risk for any complications in pregnancy. There's also a very uncommon outcome would be to have like an ectopic pregnancy implant in a scar in the uterus. It's very uncommon. So I wouldn't worry about that too much.
And I just often those risks are mitigated by just having a C-section for your delivery.
Someone else is saying that they are getting iron through IV treatment to replenish loss of blood/iron. Does this affect fertility chances or have any long-term effects on the body?
I think that sounds like a really good plan. IV iron is a really excellent treatment for people that have anemia from blood loss. So I think that's a really important step that you're taking to protect your health and to boost your own production of your blood cells to replenish what's been lost. So I don't anticipate that to have any negative effect on your fertility at all. I think sounds like a good plan.
Sorry, I'm just trying to go through some of these because a lot of these we've touched upon so many of the topics.
Speaking to the IV iron, we actually do work as a multidisciplinary team. So often if you have heavy bleeding or abnormal uterine bleeding, we'll have you see a hematologist who is also in our group. We have quite a few of them. So, we have several patients who have pretty significant anemia, and we'll have them see them preoperatively, sometimes postoperatively, and they'll make a plan for IV iron infusions to boost supplies for surgical preparation, but also quicker recovery post-op.
We have someone else here who is saying that they found out recently that they have a Subzero myometrium fibroid located in the middle fundus region, and the size increased from 2018. Is this considered fast growth? They're considering pregnancy and they're not sure how concerned they should be.
Did it mention how much it grew?
So the current size is 5 by 5.8 by 4.1, and it started at 2.8, 2.6, 2.4.
In 2018, though.
That could be normal. So the issue with the fibroids is that your reproductive hormones should be very active. And so, a growth of a fibroid about 0.5 centimeter to 1 centimeter a year, we wouldn't really be too concerned about that.
And then let's see here. We have someone else. They've had multiple fibroids removed. They have a few that came back again. They're trying to get pregnant. If they decide to have the fibroids removed again, would it affect the uterus and difficult for me to become pregnant, or even have complications if they become pregnant? So I know we've touched upon a lot of those as well. And just trying to see if there's any others that we've missed. And I guess another question here is, what is the typical recovery time after fibroid removal?
It's a really good question, actually. That's a really valid one. Hysteroscopy, outpatient. Robotic laparoscopy, outpatient. Open procedures, 1 or 2 days in the hospital. In terms of recovery, we've talked about getting pregnant quickly after hysteroscopy. Most often it's just a little bit of bleeding, some cramping. People are often back to work in a day or two. More of an anesthesia hangover is what I tell people, and you're back into life. Then in terms of like minimally invasive procedures, so the little incisions, again, still home the same day. The restrictions really are more lifting, pushing, pulling. We don't want you to end up with one surgery needing a second because you need an umbilical hernia repair. All those fibroids have to come out of somewhere, and those big fibroids are taken out of those little spaces, but that little space is a weakened area. So the restrictions really are nothing more than about 10 pounds, or nothing that pulls on those incisions. People go back to work pretty quickly, depending on your job, but 2 to up to 6 weeks for some, depending on, anemia and the complexity of the surgery. An open one is similar, 2 to 6 weeks, and we can always adjust that and individualize that as patients need them.
And another question here is, how will I know that my treatment has been successful?
If your symptoms get better. So again, we mostly intervene if you're having symptoms. And then, for fertility, obviously, there are certain fibroids that we have to remove that have effects on fertility, as discussed before. It's a little bit harder to know whether the fibroid is going to be successful, or a successful pregnancy would be the success story in that situation. But in general, if your pregnancy is better, we think that's successful, you haven't had any complications associated with the surgery, then we think that that's a successful outcome.
And someone else is asking, how often do fibroids spontaneously involute?
Involute? Yeah, people ask me a lot of these. So I probably am, I lived in California, so I'm very much into integrated medicine just because it's very integrated into the healthcare system over there. We had a whole institute of integrated medicine. And I have seen many, many patients on every single regimen you can think of to try to get their fibroids to shrink without taking some type of medication or procedure. I will say that it is rare that you see fibroids shrink significantly with a lot of these interventions. I have seen tons of patients do well symptomatically and not need to have a procedure or have surgery, but it's not so common that I see them shrink so much. So I really think of them as a way of potentially preventing things progressing forward rather than kind of reversing issues. We do have medications that can help to shrink fibroids, but they're limited because many of those medications put you in a false menopause, which can have some effects on your bones and weaken your bones and increase your risk for things like fractures, and just not great. So we can't keep you on those medications for a long extended period of time. Those are generally things that we do to bridge you to surgery or make your surgery less complicated. Or if you're towards the end of your reproductive years, close to menopause around the age of like 49, 50, sometimes we can use those medications for a shorter period of time just to bridge you to menopause when fibroids tend to shrink or at least stay the same size on their own. I don't know what you guys are doing. I know your thoughts. I would be interested to hear my colleagues' thoughts on that answer, on that question.
I mean, I think you hit it on the nose. I really feel like we wish there was a better answer. You know, we're doing a ton of research in this field, and sometimes it feels like the options are kind of still the same. And it's not that none of us are trying or doing research to figure it out. In fact, we really are, but we're learning by, you know, a negative reality from that study is that there hasn't been a clear-cut treatment that works best. So none of these fibroids are your fault. You didn't do anything. Your diet didn't actually create this problem. This isn't like a lifestyle decision that you made that created all of this. This is just kind of a deck of cards that you were dealt, and we got to figure it out. So I don't think they involute, not really much significantly. I do think they change in characteristic. You know, they can think of like a softball turning into like a sponge over time. That can be a kind of as you reach menopause, and sometimes they can take the reverse and calcify and get really hard too. So they change in characteristics with different aspects of your life. There's not really a perfect science to it, but for the most part, if they're in a bad spot and they're causing symptoms, we tend to have to take them out.
All right, everyone. Thank you so much for answering so many wonderful questions and just being so engaging and informative. I know that we are just about at time, so I want to be mindful of everyone's time and all of our attendees. Thank you for joining us tonight. We really appreciate it. If anyone has any questions, you can, of course, email me, and I am happy to direct them to our wonderful team here. Thank you all so much. Have a wonderful evening, and we hope to see you soon.